Welcome to PCR London Valves 2024. My name is Maarten Vanhaverbeke, an interventional cardiologist in Roeselare, Belgium. And I have the pleasure to be here today with Ole de Bakker. He's a structural interventionalist in Rigshospitaal Copenhagen, Denmark. Hello, Ole.
Yes.
So the topic of today is access in TAVI. So Ole, can you give us a heads up? What is the current evidence of access in contemporary TAVI procedures?
Yeah, thank you, Maarten, for this question. Yeah, well, first of all, we have actually some new updated data on this, particularly from the TVT registry in the US. We see that for contemporary practice, like this year, last year, that for 94% of cases, of TAVI cases, these cases can be done by standard transfemoral approach, okay? Mm-hmm. And then in about 1.52% of cases, there is still transfemoral access being used, but with use of intravascular lithotripsy, some ancillary techniques to push your way through in the transfemoral. And then we are still talking about 4% of real alternative access, alternative routes. We see in the US that 2%, this has become the dominant alternative access, is transcarotid. And then the other 2% remaining percent is a little bit a mixture of different approaches, axillary, transaxillary, you have some transcaval, and very, very few transapical and direct aortic stills. From the European side, we have data from the European survey from Dr. Rosseel from Aalst in Belgium. She also found similar findings, so around 5% of alternative access needs in contemporary practice. Slightly different in Europe, there's more dominance of the percutaneous transaxillary approach, slightly less of the transcarotid, but you also see exactly the same, that all transthoracic approaches, whether it's transapical or direct aortic, are kind of disappearing or actually almost not used anymore.
Yeah, okay, but with all these options available, what should operators then choose? What is in your opinion, how should be the strategy if they have to go for an alternative access?
Yeah, look, I mean, if you're facing a challenging access, first of all, I think it's super important that you look to the expertise in your team. What expertise do we have? Are we extremely strong in percutaneous, managing our own peripheral accesses, complications? Are we good in that? Or do we have a surgeon on board who's really particularly good and interested in transcarotid, or maybe surgically assisted transsubclavian? Or did you become very competent in going percutaneous transaxillary? So it's very dependent on which expertise you have in the team. Of course, then also very much on the patient's anatomy. And then I think there is really agreement in the community that, as I said, we only have around 4% need for alternative access. Let's say an average TAVI program of around 200-300 cases a year, annual volume. That means for that center, they do around 10 to 15 cases with alternative access. So I think it's really important that you try to really become an expert in one particular alternative access, that you don't dilute this further in, I do 2-3 transapicals, 2-3 transaxillary, 2 transcavals, I do 2-3 transcarotids. No, that's probably not the way to go. If we want to build up a safe and efficient TAVI program, also for the alternative access, I think it's better you try to qualify and become an expert in one particular access.
Yeah, that makes sense. And you already mentioned it. We already also know that there's facilitated procedures to have calcium modification. What about these tools? Should we incorporate them into our practice?
Absolutely. That's what I personally think. That's, of course, again, depending on the expertise in the team. But I think it's the time to become an expert in this. Yes, that if you have a challenging access, that your first reflex almost is, could I manage this in a safe way, transfemorally? And then, of course, what challenges do we challenge typically in access? It's either enormous tortuosity. We can overcome this very often with stiff wires and with an introducer sheet. Combination of tortuosity and calcification, that's very often, that's the cases to look for real alternative access. But if it's purely a calcific access based on peripheral arterial disease, which is calcific disease, then I think there are really good tools to modify this calcium. We have intravascular lithotripsy, which has shown that it's very useful. It prevents complications, it prevents vascular rupture, it prevents spiral dissections. You can do your case in a safe way. Or now a new kid on the block is orbital atherectomy as well, for some more nodular calcifications, not these really circumferential calcifications. But again, I think it's important that you have to learn this skill sets, and you need needed materials ad hoc in your cath lab as well. So I think the message for this is try to stay transfemoral, because it's the way we used to work. And typically, if we do something, we can stay in the same approach as we typically work, your outcomes will be the best. And if really you need to look for an alternative axis, try to become really good in one particular alternative axis. That's probably the way to go in contemporary TAVI practice.
Well, that's great, Ole. You wrapped it up perfectly. So thank you for your insights.